Good afternoon and welcome to all of our participants to the first of our Ethics in Head and Neck Cancer seminar series. I'm David Wiesenfeld, Lead in Head and Neck Research and Education of the VCCC. I'd like to acknowledge the traditional custodians of the lands on which I and today's presenters and audience are located. I would also like to pay respect to elders, both past and present, and extend that respect to other Indigenous Australians present online. Before we kick off today's program, there are a few housekeeping notes. This is the first of 3 head and neck cancer webinars. You can register for the upcoming events via the VCCC website, where you can also browse other upcoming VCCC workshops and events. Please note that today's webinar is being recorded and will be made available to view on the VCCC Open Learning page once the final data is published. If you have any questions for today's presenters or panels, you can do this via the Zoom Q&A function. Please submit your questions throughout the presentation and we'll aim to answer your questions at the end of the session. It's my great pleasure to introduce Professor Claire Delaney, Clinical Ethicist at the University of Melbourne, Royal Children's Hospital and Peter MacCallum Cancer Centre. It's been a great pleasure over the last few months working with her and our organising committee to develop this 3-seminar program. The organising committee members are Ms. Laura Winter, Community Representative, Professor Hui Gan and Dr. Maury Wadder from the Austin Hospital, Ms. Carly Fox from the Peter MacCallum Cancer Centre, Ms. Felicity McGee from the Royal Melbourne Hospital, Dr. Ben Dixon and Ms. Rebecca Barnett from St Vincent's Hospital, and Dr. Jasper de Boer from the VCCC. Over to you, Claire, and thank you all.
Thank you, David. I'll just share my screen while I get organised. Okay, that's good. Yes, thank you, David. Thanks very much for your role in getting this seminar series off the ground, for organising these seminars and for inviting me to be part of them. And thank you also to the panel for contributing to the planning and being so generous with your time and expertise. So I'll just go back. The question that is posed for this first seminar is, we can treat, but should we? And another way of phrasing this ethics question is to ask, is this the right treatment for this patient? Now, on one level, this question should be fairly straightforward to answer because, after all, we're all very familiar with foundational ethical principles which guide health professional work. The goal of health professional care is always to promote the well-being of the patient, including the physical and psychological well-being, to minimise harms and burdens that can flow from treatment, to maximise any benefits you're able to offer, to respect and promote a patient's autonomy, their privacy, dignity, and their preferences for their own health and well-being, and to use whatever resources you have available to you as fairly and equitably as you can. But these principles don't always help to answer questions in particular cases, such as whether to offer immunotherapy or whether to go ahead with radical therapy or who should be included in decisions. The principles are high level. They guide actions, but they don't specify actions. People will interpret the principles differently. What is seen as a benefit for a clinician caring for a person may be quite different to their patient's conception of what a benefit is. The principles may directly clash with one another, and even where there's agreement about what is best, there might be restrictions or limitations. And we've certainly experienced a year or two of COVID restrictions impinging on how we can go about work. So ethically tough cases involve just these types of complications and clashes in principles. And they have the following general features. They involve choices, all of which are not great for a person, or they're just plain bad choices, but there's still a choice to be made. All of the choices are legal, and reasonable people will disagree about which choice is ethically preferable. As mentioned in the previous slide, fundamental principles of bioethics can be in conflict in tough cases. And yet, a decision has to be made and something must be done. And in the context of head and neck cancer, a few other features may well be present. There may well be time urgency, and the treatment as well as the cancer can affect a person's appearance, their identity, and of course affect really important functions such as eating, breathing, and speaking. And again, both an action or an inaction will affect the patient. And I'm going to suggest that there are 8 ethics competencies that can help in addressing these tough cases. The 2 main ones that are most important and that I hope that this seminar series will highlight are an awareness of your own assumptions and the assumptions of others, including your patients and colleagues. That's a basic requirement for you to be able to recognise where your judgments are coming from. And on that basis, having the ethics language and some ethics concepts that enable you to ask ethically important questions and to discuss the ethical aspects of cases. And Schwab suggests that having an awareness, having this type of awareness of your own professional moral perspective, representing just one moral prism through which to make judgments, requires a type of epistemic humility, which could be translated, I think, to a genuine curiosity about seeking different perspectives and how other people are thinking. So through the next couple of cases that we're going to discuss in this hour, and hopefully through your questions and comments and the panel's comments, we'll practice just that, those ethics competencies of raising our awareness of different ways of understanding the ethical dimensions of these tough cases. So I'm going to start with this case of Mary, who's 85 years old, lives in Croydon with her husband Jim, who has bad knees and is largely chair-bound. Now, although she's 85, I think these days that equates to a good 70, 75 in the old days. She cares for him full-time. She remains independent, taking care of all the household duties, and she's still shopping and driving. She is an ex-smoker. She quit when she had a myocardial infarct 3 years ago, and she had 3 stents placed at the time. She uses a puffer for COPD a couple of times a week. Mary and Jim have 3 adult children. 2 of their children live interstate and she doesn't see them very often, but their daughter lives nearby and she's an ICU nurse and is in regular contact. Now, Mary presents to a surgeon with an ulcer on her right buccal mucosa, which is biopsied as moderately differentiated squamous cell carcinoma. She undergoes a workup and staging. The recommended surgical plan is for radical therapy, surgery and radiotherapy, involving ipsilateral neck dissection, free flap reconstruction, and the surgery will also involve tracheostomy and a nasogastric tube. During the discussion, the idea of primary radiotherapy to the lesion is also raised as an alternative. Now, Mary's response to this is to say, do whatever needs to be done. She's very prepared to go with the surgical option. She sees this as preferable to radiotherapy. The way that it was explained means that she believes that the radiotherapy is less of a curative option. She's pretty sure she'll bounce back from this surgery, and she really needs to remain well to care for her husband, and she's functioning pretty well at the moment. But Mary's daughter rings her mother and says, well, actually, she doesn't ring her mother, she rings the surgeon, and she thinks that the surgery shouldn't go ahead. She says her mother doesn't understand the risks or the likely effects of this treatment. And she goes so far as to say that from her perspective, having this surgery at Mary's age is futile. And here's where I'm going to ask the panel to gauge what their reactions are to this situation, and to think and to comment on what they think is most at stake here in ethical terms, whether they're concerned about the potential conflict between Mary and her daughter. Her daughter has been nominated as her next of kin, so she'll be the one making decisions in the future. Mary's capacity, or whether you're concerned about Mary's capacity, whether she actually has sufficient understanding of this surgery, or whether you have a view about the pros and cons of radical therapy or primary radiotherapy. So I can ask the panel to turn on your cameras, and I'm going to ask one member of the panel, Laura, who's been a patient of head and neck cancer, who's had personal experience, to comment first on where you're sitting in relation to what's important for Mary.
Thank you. For me, the answer, pretty much what Mary is looking at going through. I feel that for her, she might misunderstand what curative looks like. Hearing the word cure, then you're faced with that. She doesn't understand the side effects of that cure. And her independence means so much to her. For me, I went through the surgery at 37 and needed a lot of support. If she doesn't have that support, and she is the support person for her husband, I think for her, the radiotherapy would be a better choice for her age, and what is important to her, which is being the support person for her husband and living out her time doing what she wants to do.
Right. That's really interesting. I remember asking you about that very early on, and so you're coming here, you're mainly focusing on this second point, which is worried that Mary might not understand what this surgery involves.
And I think when you're given a diagnosis, it's impossible to listen to everything that is being given to you as information at the time. So I think it's natural that you, in a traumatic situation, I guess, for lack of better term, you pick out the bits that you want to hear and what you can digest and try and fit back into the life that you know. But it doesn't end up like that. The life that you think is going to happen after that operation looks very different to what she is probably envisaging.
Yeah, that's really interesting, and I'm interested to hear from perhaps one of the surgeons on the team to hear your view about that. Maybe Ben.
Sure. So I think the MDM recommendations are correct. The curative option here is surgery, reconstruction, post-op radiotherapy, but it is a lot to get through, as Laura's been explaining, for anyone to get through, let alone with comorbidities and at that age. There are a couple of issues in terms of, well, I don't think we can really speak to Mary's capacity with the information we've been given so far. I think that needs a bit more of a discussion with Mary and a bit of an understanding of her capacity and whether there's anything impairing that. A couple of comments though. She seems to be doing it for her husband, and this is difficult. He's 94, but you know, next year he might be 95 with bad knees, and she might have recurrent cancer and be terminal, when she could have been potentially cured with a more radical therapy. So it's difficult. We don't have a crystal ball with these things, and we don't know whether giving a sort of inferior treatment in terms of cure, such as radiation alone, is going to get control for 3, 4, 5 years. Probably not. Or whether it's only going to be a few months and then it's returned, and then we're in more bother. And her husband's still alive, still with bad knees and still with needs. So I think you need to address her husband's needs regardless and make the right decision for her and her own health. The other bias in here is potentially her daughter's views as well. And I think you need to sit down with the daughter and talk about, you know, she's an ICU nurse. She probably hasn't seen head and neck cancer survivors and patients at their best. She's probably only seen them at their worst. And so she may have a number of biases there as well, and you might need to explain the process and the outcomes to her a little better, because she might assume a number of things based on what she's seen. But for a lot of our complex head and neck patients, we avoid ICU. They only see the ones where something's gone wrong, or there's a really sick patient, and certainly we wouldn't be planning to send a patient like this to intensive care unless there was a particular issue. So I think those need to be addressed. So I think there needs to be a bit more background into what the wishes and the wants are of the family and what the capacity is before you can make the right decision here. But certainly there's plenty of people in their 80s who get through this surgery quite well. Buccal is a little variable in terms of how extensive the surgery is and whether there's bone either in the mandible or the maxilla that needs to be resected, and sometimes both. And so those assessments are important as well about what you think the functional outcome is going to be like. So a number of additional things you'll need to know, but it is going to come down to quite a few judgments in the end. And they do take our advice pretty seriously. So as a surgeon, you have to really be careful how much you sell one way or the other, because we can influence things quite a lot.
Yeah, I think there's a number of things I want to follow up in those comments. I mean, certainly you reinforce that need for learning, finding out where others are coming from. You know, the perspective of the daughter and her ICU experience, maybe giving her a particular slant on things or understanding. But also it's quite puzzling how you explain something which is so uncertain. Does anyone want to comment on that? How, you know, and the way that you can provide information and choices, how you assist a person to understand?
Maybe I'll speak a little bit from a radiation oncologist point of view. So when we discuss the treatment outcome expectations, in terms of tumor control and survival statistics, it's quoting percentages. So it's not that difficult to communicate that, but I think it's quite hard to understand in a real life sort of situation to an individual. The acute toxicities are quite predictable, and so I don't find that too difficult, and these are mostly reversible. But the late toxicities, so what people suffer from, and the change in identity, and et cetera, that you've mentioned up front, is very variable, and it's hard to predict. And further to that, it's complicated by the people, the patient and the family, and everyone's perception of what that means to them and how that impacts the quality of life. Is very variable, and that's very, very difficult to predict, let alone communicate. I think it was great to hear from Laura initially, and I'd really like to, understand, what you would have liked to have understood when you made the decision.
Yes.
So. But in terms of radiotherapy treatment in this context, again, I'd like to know what the exact extent of the tumour was, and that does have bearing on how inferior radiotherapy may be. I think this case had retromolar trigone extension, in the brief I saw, in which case I would say that the control probability is far inferior. That's not to say that there's no chance of cure, but what constitutes an acceptable cure, and it depends on the trade-off, in the acute and long-term, consequences. And again, that's quite difficult to communicate.
I'm interested in Felicity and Rebecca's views about this, because I think that in your capacities in allied health, in nursing and in speech pathology, sometimes the allied health people have more time with people like this than, spend more time talking to them. So do either of you have a view about what's ethically important for Mary?
I can probably speak to that, Claire. I guess, in a case like this, once Mary had been, had a consultation with the surgeon, she would then get passed over to myself to have, start to have those discussions about education, about what this surgery looks like, what the recovery is like. And I guess that's where it comes into play that, I guess when you were saying before about how do you communicate, like what's this going to be like for the patient? I guess myself and my colleague that do this sort of every week, we just give it to them really real, like we sort of say, if you go through this surgery, you're going to be in hospital for 3-4 weeks. This is what's going to look like. You're not going to go home on a regular diet. You are going to, have X, Y, Z happen within those couple of weeks at home. But then also, with looking at her family situation, if she's got 2 kids that are, estranged and a daughter who's busy in ICU, if she's going to go through 6 weeks of radiotherapy, how is she getting to radiotherapy every week? What does that look like for her husband? Who's taking care of her husband? They're the sort of conversations that we start to get down the track of, I guess her comments, I think, were bounce back. And I guess that would probably worry me in sort of saying to her, well, this is 6 months that, your life's going to be turned upside down. And, that's best case scenario.
So does it matter if it sounds like it does matter if a patient's expectations are unrealistic, and you sort of need to do something about that?
I think so. I think, bringing them back, as I think Laura said before, talking about that curative, curative looks a lot different at the end of this journey. So I think just bringing that realism, it's not going to be, even if you get to the cure at the end, it's not going to be all sunshine and rainbows, I think is really important.
Yeah.
And I think actually right at the outset, prior to any decision regarding surgery and radiotherapy or radiotherapy alone, there's a real opportunity there to understand more of what the patient's goals are and what they're expecting from themselves.
Yeah.
So in those very early appointments, trying to get to know Mary and her situation a little bit better can even come before all of the download of information and all of the education starts. I do agree with Ben that involving Mary's daughter, particularly as a potential medical decision maker at some point in time, involving her early in the discussions and having both Mary and her daughter hear the same information is absolutely critical.
Yeah. So would the surgeons, if Mary got this information and chose and then decided to change her mind, Carly, would you be happy with, would you go with that? Would you think that that's ethically reasonable?
I think that's ethically very reasonable. I'm thinking, listening to all of these discussions, right back to your very first ethical principle where all decisions are bad. Even though, you know, choosing cure, you might think intuitively that that's going to be a good choice. I'm going to choose a cure. It's not. It's an awful rocky journey. And she's walked into this saying, my number one goal here is to stay well so I can look after my husband. And none of these choices allows her to realise that goal in the way that she's going to want to. So it's a matter of balancing which of those is going to get her to be able to realise that goal as well as she can. And in the short term, perhaps having radiotherapy will keep her more well and more mobile because she won't be in hospital and still able to complete her carer role. But how long will that last is unknown. So it's difficult. But yes, I would very much support that if she said, I'm going to go with radiotherapy, understanding what her priorities are and making sure that her daughter hasn't affected her decision-making too significantly with perhaps some biased views on what surgery is like. You know, part of our role is to make sure that everyone gets the right information so they can make their decision.
Does this have an urgency about it, a time urgency? Because what I'm hearing is there needs to be quite a lot of conversations, getting to know Mary, and spending time discussing. Is there an urgency around this type of problem?
Yeah, there is. These discussions usually happen over the course of a couple of weeks in patients who have tumours that are threatening airways or fungating. We can move them through a little bit faster, but we usually meet them 1 week, formulate a treatment plan the following week, and then it's a week or 2 or 3 until their operation if they have it, or a week or 2 till they meet radiation oncologists. So there is time, there's lots of discussions, lots of opportunity to come back and revisit points of discussion if the patients and their families are unsure.
Yeah. So this is a line ball decision. You would go, it's ethically reasonable. Is that what I'm hearing? And I'd be interested from if there's anyone in the audience who wants to put into chat whether they have a view as to whether they, as the surgeon, would promote this surgery, or whether they would present it as very much it's a 50-50 option where you're aligning here. For someone like Mary, is it really? I might have to take it out of the ethically tough case if it's easy to make this decision, or whether they're really, how you go about talking to Mary about these options.
I think the point that Maury made earlier about whether it's into bone and really what control you're going to get with radiation is really important here, because you don't want to be saying that's fine, go with radiation therapy if you really believe they're going to be in a bit of a hole 6 months later. And so there's some fairly small details that go into our decision making into how much we accept that that's a good option for them versus whether we sort of push forward recommending the operation. But I think, I mean, the idea was to, I suppose, have this case as being a bit borderline, and she does have multiple comorbidities. So I think it's very reasonable, but you really want to just check that you're not going to create more problems that wouldn't be better off with a surgery up front. On one of the points before as well is that often we do have limited time to make these decisions and get them to the operating theatre. And I know with our service often we're seeing them, booking them for cases and working up for potential radiation at the same time in parallel, which is practically what needs to happen, but can be confusing for patients when we're getting consent forms ready for a big surgery, but saying, oh, you can still have radiation, you think about it, and it becomes quite a confusing scenario for them. But,
to take in, And there's a couple of comments in the chat about that, whether, to go abroad and have that geriatric assessment to help with decision-making processes and to help Mary's capacity, I'm presuming that point is making. There's another...
She'd also require quite a thorough anaesthetic workup for those comorbidities as well. So there would be quite a bit of pre-surgical workup, I would imagine, for Mary.
Mm. And Jennifer's making a good point here, and one I wanted to follow up with, and then we'll move on to a couple of ethics concepts I want to talk about in the next case. But the cure is such a seductive word when you've just been given a cancer diagnosis that, and I'm also interested in Maury referring to a percentage, and I think do surgeons talk about cure in percentage terms, and what is that a help? How do you make sense of percentage terms? Do you talk about it, what those numbers mean, I suppose, as well? So Carly, for example, or Carly or Ben, do you always use percentage as this is the outcome we're hoping for in percentage terms?
I might defer to Ben on that one as the oncologic surgeon. He probably has more of these conversations than I do. We can talk about flap success rates and so forth, but right. I think the question here is about cure versus not cure, isn't it?
Yeah.
Yeah, I think it's difficult. In some situations, we've got good data and we understand the comorbidities of the patients. And so in someone with an early stage who's 50 with no comorbidities, it's a bit different to someone who's 84 with multiple comorbidities as well. So that influences things. And you don't want to offer too much hope in that setting. One important conversation to have in terms of cure is that the cure rates are with surgery plus post-operative radiation therapy. In most of these cases. Now, it might be a very early buccal cancer. There'd be very few buccal cancers that get adequately resected. It'd have to be pretty early to be surgery alone. Right. So that's an important part of the conversation as well. So it's quite a lot of treatment to get through to get to that cure. And we have to make sure that that people have, the understanding that it's not just surgery, it's surgery plus radiation therapy for radical. So it's difficult often to put numbers, and I think in this scenario, certainly without seeing this tumour and the imaging and whatever the staging, I think it's very difficult to say what the chance of cure is. But, we'd be looking at with radical therapy, just say some ballpark figures there, we might be saying, well, we might have a 70 or 80% chance of curing this if you can get through radical therapy versus, less than 50, maybe 40, 30 with radiation alone, if that perhaps. So, I mean, they're the sort of figures that would come to mind, but they're very individual. And as I say, oral cavity in this age group with these comorbidities, it's very difficult to put figures on.
Mm. Yeah, and there's a few. Is no treatment an option? That's another. And it goes to that aspect of tough cases in head and neck cancer, especially, that no treatment can be, in fact, a worse option, or by no treatment, I'm presuming just palliative treatment. But is there a third option for Mary, or is it just those two?
I guess so far we've talked about options of radical curative treatment with radiotherapy being an inferior option, which I think is true in this case. But there are active palliative interventions that we can, provide, like palliative radiotherapy. Yeah. And in a case like this, after thorough discussion, it may be that they want to, they absolutely don't want to go through radical treatment of sorts. So that I think it's a reasonable option and discussion to be had.
I'm going to go through to a couple of concepts that I think have been raised in this discussion so far. They're not brand new concepts, and you will have heard about them. But in addressing these types of tough cases where all of the choices are bad, it can be useful just to explore the meaning of some of these principles in a bit more depth. And a bottom line ethical concept about benefits and burdens, which gets you a little closer, perhaps, to explain to sort of communicating with the patient, is that any intervention should be reasonably expected to produce more benefits than burdens. Now, of course, the devil's in the detail about what you're talking about in terms of benefits. And for Mary, benefits are not only, reducing or getting rid of the cancer, but also enabling her to be healthy enough to achieve the goals that she has stated. So weighing up many aspects of the treatment and not just the clinical components seems ethically really important when looking at benefits and harms. Remembering that benefits encompass the physical, the psychological, social, spiritual, and even financial effects on a person. From an ethics perspective, the patient's perspective on what is a benefit or burden to them has ethical priority. And this is definitive for a person who has decision-making capacity. And even for a person who has some diminished capacity, it still matters a lot, this ethical ideal. And just being clear about that can sometimes help shape the conversations that you have and the focus of those conversations. The second ethics concept that we've been talking about and that was raised first up really was whether or not Mary could even understand the complexity and the short-term and the long-term effects. And so the principle of autonomy is that, patients are ethically entitled to make decisions about their own health and healthcare. Well, that sounds grand, but there are a few things that get in the way. One of the limitations, or a couple of the limitations, is even when patients want something done for themselves, which isn't quite the Mary case, but clinicians don't have to respect and do everything a patient asks them to do. They can make a professional judgment that this is in the patient's best interest or not, or that it may be harmful. So that's one limit to patient autonomy. The use of resources doesn't usually get spoken about explicitly, and it doesn't usually get in the way, but COVID has introduced how resources do matter and can matter. There are a few other things that influence patient autonomy, and they've been mentioned already. The role of the clinician to advise, in advising and assisting the patient to deliberate about values. This classic paper from 1992 talks about 4 models of the physician-patient relationship, and they talk about the informative model as more like a shopkeeper model. You just give patients, you could have this surgery or you could have radiotherapy, and you choose. But they suggest that the deliberative model is a more helpful one rather than this informative one, where you actually help a patient consider their values and what's important to them, and how to think through that as a role in promoting a patient's autonomy. I think relationships, the culture and the family also influences a patient's autonomy and can't be ignored. Patients aren't, such an individual that the influence of their family is not going to have an effect. And then the other thing that I think is important to raise, and that is just the other thing that can affect your autonomy, your capacity to make a decision as a patient, is the amount of time and opportunity you have to think and reflect about what matters. And I remember speaking with Felicity just recently about this, and she made a really nice point that once you're in the system, it's super busy and there's just so many people to see and talk to that it can have an effect on your capacity even to think straight. The final one is futility. Mary's daughter thinks that this is futile, and futility always needs to be explored, because an intervention is only futile in relation to a particular goal. So they're not globally futile. Patients may have different goals from the treating team. What's futile to one person may not be to another. So it can be unhelpful to state treatment is just futile. So that's a quick run through a few concepts which we could spend a few hours on each one of them, but I think they were all raised in the discussion so far. Now, I'm going to move to the next case and go through this case quite quickly because the essential nature of this case is that Leah, a young woman, goes through 3 stages of treatment. She lives in Fitzroy with her husband, 1-year-old and a 3-year-old. She's a partner in a law firm, doesn't drink and smoke, and in fact, she's been a national representative, so she's pretty fit, has been pretty fit. But she presents with an ulcer on her left lateral tongue, which is biopsied as a moderately differentiated squamous cell carcinoma, and she's appropriately staged to have, and I presume you're all going to know what that means, squamous cell carcinoma of a particular size. Sorry, I'm missing my arrow here. So the recommendation is operative management of partial glossectomy, radial forearm flap, reconstruction, and ipsilateral selective neck dissection. And the counselling that she receives is very much focused on cure and returning to all functions. There's acknowledgement of potential for mild speech and swallowing deficits in the medium and long term, but everyone is expecting that she speaks to that she'll be able to return to work. Now, if we could launch the first poll, I just would love to hear from, just if you could pick whether this presents no sort of question for you, whether you agree that this recommendation of this type of treatment is ethically appropriate. The benefits outweigh the risks. It seems to be in line with what we know of Leah's wishes, although we don't know very much, but we presume she's on board, or whether you're not really sure about whether this is the right treatment or you don't agree. So if we can share those, you need to be quick to vote on this one. I think if you can share the outcome, Cynthia. There we go. We're getting most people agreeing at this stage, and there's a few that are unsure. And I might come back to you. Hopefully you can remember what you said, because we're going to do this a couple of times. But no one's not agreeing. So that's an interesting finding. So we'll close that one and I'll keep going. 9 months later, Leah, so the surgery goes well. 9 months later, she comes back with a right neck mass, and this is determined to be a recurrence of the squamous cell carcinoma. Neck dissection on the right and left is recommended, and there's a small positive lymph node in the left level. The lymph node on the right is large and matted, will require partial resection of the hyoid bone and sacrifice of the hypoglossal nerve. Post-operative chemoradiotherapy is also recommended given the imaging. So the counselling she receives now is that there'll be further effects on her speech and capacity to swallow, but she's expressing a very strong sense of wanting to fight this cancer and wanting all treatments possible. So can we have the second poll question now, and if hopefully the same people will vote again on whether they agree still that the benefits of the surgery, from what you know, outweigh the risks and still in accordance with Leah's autonomous wishes, or whether you're starting to waver at all and think that maybe this is the second treatment, benefits might not outweigh the benefits, or whether you're unsure. And I know there's lots and lots of, I didn't give you the option of it depends, but it probably does depend on a whole lot. But just your intuitive reaction, what have we got here? So if you can share. Looks almost the same. So people are staying with the first option that most people agree. And I'm really keen to know about that 6 people, and it was 8 last time, who are not sure, but we'll have a discussion. But she does recover well from the operation, and she completes chemoradiotherapy, although it was pretty extensive surgery. 12 months later after that salvage surgery and 21 months after resection of her initial tongue carcinoma, Leah presents with a left submandibular mass. It's firm, fixed to the mandible. The biopsy and staging confirms this is a further recurrence, this time involving bone, although there's no evidence of locoregional disease elsewhere. She's now experiencing sleep disturbance and anxiety. She's seeing a psychiatrist for depression. She has concerns about worsening disfigurement and pain. She's worried about managing her own and others' fears around her dying. And she's worried about likely dependence on PEG tube with oral feeding only for comfort. She's spoken with another patient on an online chat forum who's had a similar cancer profile and been successfully treated with immunotherapy. And she's stated now she doesn't want further surgery. She doesn't think she could cope. The surgical recommendation, however, is to resect the mass with wide local excision, resection of both the intraoral and extraoral skin, salvage neck dissection on the left, and reconstruction with 2-paddled free fibular flap. That was what was recommended in the MDM. Final poll, where you're sitting now with whether you would agree it's appropriate to go with the recommended surgical option, whether you're not really sure whether this was right, or whether you've actually changed your mind and think that this is not the option that should be proposed or pushed for Leah, and that her choice should be that she's expressed she doesn't want it. Let's have a look at what people are thinking now. Okay, so there's now, this third one has seen a shift to a lot more who are unsure, and a couple who don't agree, and much less agreeing. Thank you for that. Just go to, so this is, I sort of expected that there might be a shift when we got to the third presentation, and I'm thinking that as we got to the third one, that people are starting to think futile might be too strong a word, but certainly the burdens are starting to outweigh the benefits. Now, I'm going to ask the panel again whether my representation of that and the way people have responded, what they think about this, or is anyone on the panel thinking that they would really push for Leah to have this third surgery, and why? Or whether they would go with Leah's request, or whether they have any doubts about it.
It's a very tricky decision, very, very tricky. I think so saying burden outweighs benefits, it depends on her goals. So it's really important to establish those from the outset. She's 33, she's got a young family, and to her, she's a hypothetical patient, but duration of life is probably very important to her, almost regardless of the quality of her life. given that she's so young, whereas someone who's much older, who's had all their life left to live, or doesn't have much life left to live, that's not going to be as important. They'd rather prioritize quality. So working out what her priorities are prior to trying to make a decision is going to be super important, and that will definitely help guide these decision-making processes. The other thing is to think, is there an alternative to this operation? Is it just nothing? Is it immunotherapy? How well does that work? That's still a new treatment. We don't know what the outcome is going to be from that, and getting input from all the teams. Radiotherapy, I think she's already had, so it's not an option to have that anymore. Very, very tricky.
I'm interested in that idea of duration of life over quality of life. And I might just ask Laura again, because you had a view about Mary. What are you thinking about Leah?
As a mum of young boys myself, I can see what Charlie is saying about the duration. You want to spend as long as you can with raising the family as possible. But for me personally, it's about the quality of time I can spend with them. Knowing that if I can spend better quality of life with them, that will give me more peace, knowing the time I got to spend with them was quality time, then a long time, and not being able to participate in life the way I had initially envisaged. So I can see why she no longer wants the surgery planned out.
Yeah. And Felicity or Rebecca, do you have comments about Leah's situation?
I think in order for her to really understand what the implications of the surgery are going to be, you do need to describe it. Whether you advocate for it is probably another question, but you do need to really thoroughly describe what the implications on her speech, swallowing, and overall quality of life are likely to be. Not to say that is actually advocating for that to happen, but it helps her make that decision.
And
I guess I agree with Felicity there, and that's a bit of what I touched on in Mary's case as well. Just you've got to be that person who's giving the absolute, this is what it's going to be like, and that education. I guess for me, with Leah, I'd probably be interested in exploring how she's going with the psychologist or the psychiatrist, whichever it was. Is she in an acute bout of depression based on, all of what she's gone through already, and how is that playing into her decision making, and where she's at with that, as Laura said, quality of life versus duration of life. What does that look like, that picture?
I'm glad you raised that. I think I was interested to hear what people thought about the person's, one of the factors that influence a person's autonomous capacity in decision making is their mental health, obviously, and that can be a whole sort of tricky area to understand, and to ensure that they're making the decision with being able to think through it in some rational way, and whether depression gets in the way of that.
I think just to add to that, I think it's interesting in the case study that, in the beginning it was, that she was quite willing to fight. And, then you see at the end of the case study that, that's not what she's after anymore. And I guess, just be interesting to get that psychologist opinion.
Yeah, I think that's really important in this case. Does anyone else on the panel have other comments about this case?
Yeah, just one more comment for me. I think these cases are tough on the whole treating team as well. And when you have these cases, you come along with someone you expect to get back to a reasonable quality of life, and you really try your best, and you fail the first time, and then it recurs and you fail the second time. And because of the clinical situation, the young woman and who's otherwise healthy, everyone can sort of be trying to, literally and figuratively digging a bigger hole to try and get out of this one, which is at some stage you have to call it. But I think it's really important for multidisciplinary teams in these sort of cases, because having advice from your colleagues is really important to say, it's time to stop. Perhaps we should recommend something else, or whether they think it's worth pressing ahead. So I think this is a sort of case where you'd sort of get a bit of a gauge from your colleagues and other people who are experienced as to whether they think. And I think it's really helpful, not just for making good decisions, but for keeping the team functional and the mental health of everyone, because everyone gets hit by these cases. And I think it's good to know that everyone finds it tough and everyone's got your back and trying to make good decisions alongside you.
Yeah, look, that's a beautiful segue into the second seminar, Ben, which is about the moral distress that clinicians encounter in these types of cases. But the questions we wanted to, that we were asking in this seminar, which I want to, in the last 5 minutes, return to, were, what do clinicians take into account when deciding to offer a particular treatment pathway, and how are patients' interests framed and considered? And so I came up with these indications, which are there for revision. Are there times where there are clear indications for active treatment, where there's evidence about curative possibility? Does the indication depend on some sort of figure, or is it clear when it's just the only possible chance, and so therefore you should take it? And then when we shift up to the third time, when there was a clear shift in people's views and in the patient's view, what are the criteria for, coming to that view? So that's a really a list that I think is something I'd be keen on you adding to rather than me. Does anyone have any comments on that rough list based on the discussion so far? One of the things that the 4 ethics criteria, I think, that are quite broad, that seem to guide the question of we can do treatment X, but should we, is that in justifying your answer, it tends to hang around a justification of clinical outcome and evidence base. It also depends on an analysis of risk, burdens and benefits, and that bottom line ethical point, which is the patient likely to benefit overall? It also requires consideration of the patient's capacity to understand, and not just leaving them alone to understand, but the extent of your duty to promote their understanding. And it requires that time and opportunity for conversations and reflection amongst relevant people, which of course include the MDM team, plus and the patient's family and so forth. So the goal of today that I put up earlier was that I'm hoping to introduce and advance these ethics competencies, all of which you already have, but just bring them to the surface some more about being a bit more aware of what you think is of value to a patient and what assumptions you bring and how your values relate to basic ethical principles. Being able to even identify what's ethically important in a situation and what criteria should be brought to the table. And then being able to ask ethically important questions, especially in MDM teams where the discussion goes quickly, so it takes practice and it takes lots of supportive dialogue like this sort of thing to enable people to start articulating what they're worried about. I'm sorry I didn't get to a few of the comments in the chat about that last case, but thank you all for your contributions, and I might hand over to David to sort of round it off, or if anyone has any last comment, please speak up.
Thank you very much, Claire, and thank you to all of the panellists who've made comments. We have got a Q&A question that's come up, and I think it's a very valid question. Yeah. We won't be able to answer it. And Dear Krieg has asked, is there an occasion when a last-ditch surgical treatment is offered with a low expectation of success, but the patient still wants to go ahead? Would an MDT try to dissuade a patient or even refuse to proceed? And I am happy to answer the question. It's an unusual situation where the MDT doesn't want to proceed and the patient does. And in the end, it comes down to an individual doctor to be able to judge, do they think they're acting ethically in the best interest of the patient? In which case, I would hope the MDT would support the doctor in offering the treatment. But in this situation, it's most unlikely that any doctor of part of a team would want to proceed in a futile operation, from my perspective.
Yeah.
But I'm happy to open that up. Is there any other comment?
I think it relates to that, the limits of patient autonomy. One of them is whether the doctors, clinicians believe that the treatment is futile, and if they do, they don't have to on the basis of a patient request. It's a good question.
Yes, and the MDT doesn't actually operate. It's one person or two people end up having to operate, and they've got to believe that they're acting in the best interest of the patient.
Correct.
So Claire and the panel, I'm very grateful for your efforts today. I think we've had a very good session. We are 1 minute over time, which I think's part of the standard error for this type of problem. And 1 minute, you ought to be congratulated on getting through the section. And I'm looking forward to the next section and symposium that we have in another 6 or 8 weeks' time. So thank you all very much, and thank you to our currently 69 participants who have stayed with us, and we welcome your support, and obviously there's a need for this type of seminar. Thank you, everyone.
Thanks, David. Thanks for everyone.